Good afternoon. Hopefully everybody's filled up on ice cream and whatever, lemonade and iced tea, whatever was out there. So, there we go. Nothing to disclose. When we talk about TBI, a lot of times we say there's blood or no blood in the head, and that's kind of what drives our practice. But if you just think about abdominal pain for a second, think about how many different, if I told you somebody had left lower quadrant abdominal pain, you could probably come up with like 14 different differentials of what that really means. And for a long time in TBI management, it was blood or no blood, and that's kind of how we manage things. A neurosurgery resident or PA or attending would come by and say, admit to the ICU, Q1 hour neuro checks, and then the next day we'd repeat the scan, 6 hours, 24 hours, and then sign off. And so, for a while I was like, what are we doing? Is this really the right thing to do? And so this question of, consulting neurosurgery, transferring patients to higher level of care. I came from Detroit, Baltimore, and then I was here, and all of a sudden we had a lot of patients that we were sending in from some of our surrounding hospitals, 25-minute helicopter ride, $50,000 later, discharging the patient from the ED. And these were some of the questions in my head is, what is our role as acute care surgeons and intensivists? We manage this anyways. A lot of times all the neurocritical care is what we do. And so that being said, we know that brain injury is a silent epidemic. It's on the rise. You heard Dr. Sperry speak earlier of how, it's the #1 killer in trauma. If you look at this, the number of visits for TBI is increasing. But if you look at hospitalizations and deaths, it really hasn't changed much over time. Even DOD data, Department of Defense data, if you look at majority of TBI that they experience is what we refer to as mild TBI, almost 82%. And so most of these patients, again, not the severely injured type that we were talking about. And then even with the EPIC data we heard earlier, the biggest impact, that they saw was across, the severe type or majority severe. So traditionally, the management of these patients is with intracranial hemorrhage, blood in the head, is a neurosurgical consultation and transfer to a higher level facility. So if I'm going to ask the audience real quick, if you had a family member with a 2-millimeter bleed in their head, how many people want them to be seen by a neurosurgeon? A couple people. Interesting. So this is good. I don't have to, my job's done. So this is not about us versus them. This is more about how we can collaborate together, just to be clear. This was a nice paper by a consortium looking at the number of neurosurgeons that we have in our country to help us manage these patients. And one of the things that the workforce basically concluded was there's too few neurosurgeons available to do 24/7 call. I mean, some of the other interesting things that came out of this were that most neurosurgeons are turning over the age of 50, kind of like our population, where a lot of them are going to be retiring. And if you look at neurosurgical spots for residency, it hasn't changed in the last couple of years. This is the number of neurosurgeons per 100,000 population. All the areas in white means that there is no neurosurgeon living in that county. So you can see it's something that's definitely regionalized and brought around. So I think this is one of the things. And most, like 25% of the U.S. population is living in a county without a neurosurgeon. And we heard time to treatment is a huge impact on what we do for these patients. This commentary just came out this year, actually, which talked about, again, emergency call by neurosurgeons. This is in a neurosurgical journal. Less than 50% provide emergency neurosurgical services. 44% offer simultaneous call at more than one hospital, meaning they're in multiple places. And 20% are planning to stop taking emergency calls by 2020. So who's going to fill this gap? That's really the question. So the higher demand, more TBIs, and less neurosurgeons taking emergency calls. So what is the role of the acute care surgeon? Again, this dynamic pathology, it's not just blood or no blood. The type of blood, there's surgical bleeds, there's non-surgical bleeds, people on anticoagulants. I mean, this is a really big mix of things. And so when you talk about these things, we know that more than 90% of TBI is non-operative. It's managed by critical care. And so this study's a little older, from 2005. This is a look at the NTDB data. They looked at almost 740,000 patients, and they saw that 29% of these patients had head injuries, 74% of them were blunt, 26% had actually associated skull fractures, but the overall craniotomy rate was 8% in this entire population. And if you look at this, out of all the injured patients who required non-op management, 99% had non-operative management of their TBI. And again, this slide here is supposed to depict, I remember being a resident and we used to have these 64 cut CTs, and we were like, oh, that's amazing. Now we're at like 256, or I don't even know, 528 maybe. But we're picking up things we were never able to pick up before. There's a lot of these meniscal bleeds that we didn't know we had. And so CT scans are getting better. And so when you put this all together, majority of TBIs minor, majority is non-operative. There's a shortage of neurosurgeons, and our ability to detect bleeds or significant bleeds is really getting way better. And so the idea of not consulting neurosurgeon is not novel. What I'm going to try to do here is poke out a couple papers from different places. It's a need. When you see papers coming from different places in the United States, you know that people are dealing with this every day, and that's why we do things like this. So this was a retrospective study, 500 patients, and they looked at non-operative bleeds, intraparenchymal hemorrhage and subarachnoid hemorrhages, and then they looked at patients who had both of those bleeds. And out of the 500 patients that they had, they said, if you have a GCS greater than or equal to 13, and a traumatic subarachnoid intraparenchymal hemorrhage, they were not going to consult neurosurgery on these patients. And what they were able to basically show that these were just basically criteria that most of these patients would have been managed without neurosurgical intervention. Now you got progression and intervention. Just because you have progression on CT doesn't mean you necessarily need intervention. And when you say intervention, we're talking surgical intervention. Medical intervention such as hypertonic saline or mannitol, ICP management, that's very different. But again, that's a lot of neurocritical care, not necessarily. This was a paper done in 2014. Again, 171 patients retrospectively reviewed, looking at selective neurosurgical consultation. They felt that trauma surgeons may manage mild TBI. And so what they did here is they said, well, we're going to look at what we define as small bleeds, less than 1 centimeter, mild TBI, and they said they could be managed by acute care surgeons and a selective neurosurgical consultation. And in a retrospective study, they said if we would have done this, we would have taken our neurosurgical consultations from 94% to 65%. At our institution, I can tell you, our neurosurgeons, we go up and down. We have probably 4 right now active, some at the VA, covering lots of different places. But they have full days. They're doing a lot of things. We sat down with them and said, could we think of something else here? Here's a study from 2016, again, non-operative, head injury, 500 patients. And then what they did here, this was done at Harvard, they said we're going to admit some patients to trauma ICU, some patients to neuro ICU, some patients to the neurosurgical ICU, and see how we do between these patients. And when they admit the patients, they went through and they measured different things between survival, GOS, discharge diagnosis, DVT, and the only difference they found on when the patients were admitted to 3 different ICUs was that in the trauma ICU, there was a shorter length of stay, and a lower percent of patients actually sent to the ICU. No differences in any other outcomes in this study, and this was a prospective study that was done at the MGH. And again, most clinical outcomes were similar throughout the three admissions, regardless of who took care of the patients. This was another study, again, mild traumatic brain injury. This was done in Southern California. Acute care surgeons looking at patients with a GCS over 14, subdurals less than 4 millimeters. This came out after the big guidelines, which I'll talk about a little bit later. And they talked about small subarachnoids and non-displaced skull fractures. And again, if they were managed by acute care surgeons versus neurosurgeons, no difference in outcomes, and the results basically said financial and resource savings. And if I can ask everybody, take a pen and just draw 2 millimeters for me so we can kind of get an idea. That's a quarter the size of a pea. That's what we're talking about here and some of these bleeds that we're managing. So what's the safety of this non-operative management? Can we detect failure? Is there a need for the repeat head? How many kids are getting repeat head scans? I remember we did another study, which I didn't put in here, greater than what I called was greater than 1 repeat head. I mean, we were getting patients getting scanned 4, 6, 24 hours, and 48 hours. There's places in the country now that are, if you're on anticoagulation, you have a negative head CT, you still get admitted to the ICU, and you still get a repeat head CT. And again, I think that we're scanning way too much. It's too convenient. And then the need for neurosurgical consultation and then ICU admission afterwards. And so what is the role of us as acute care surgeons? It really wasn't defined. There's been no guidelines on the management. And what do you do with these patients? Physical exam, radiographic findings. Is CT the only thing? And there's no doubt that physical exam is the best trigger to know whether someone's going to decompensate or not. This was a 2019 paper that looked at what they called important brain injury criteria. 5-year study, prospective cohort analysis, 678 blunt trauma patients. All of them had blood in their head. And they termed this important brain injury criteria. They said if you met important brain injury criteria, you're likely to have an operation. It was great because everyone who had important brain injury criteria on initial head CT, they felt like it was 100% sensitivity, true positive that needed operations. But there was 35% of those patients met this criteria but didn't need an operation. So it was kind of over guessing who needed operation. Which brings us to the brain injury guidelines. Like I said, this is in conjunction with our neurosurgeons. We sat down 6 years ago now, and just said, let's just look at this and figure out if there's a way we could actually make sense of this. The first thing we did was we took about 4,000 charts. We went through every single chart. We went through every single CT scan, had them read, looked at their exam, physical findings, and remember, every one of these patients had blood on their initial head CT. I think that's an important factor here. And we developed the brain injury guidelines, and this was, again, with our neurosurgeons. We managed them, and then we said, well, what would happen if we managed them based on their physical exam, their CT findings, and the patient's history? And we came up with BIG. And we struggled for a long time of what the cutoffs should be. And people were like, how'd you come up with 4 millimeters? And there was one single patient who had a 5 millimeter bleed, and our neurosurgeons were like, we have to have 0. It's all about patient safety. So the first thing we did is, if you look at this, we don't even have GCS on this. It was more about, was loss of consciousness, yes or no, didn't matter. You have to meet every single one of these criteria to be classified into Big 1, Big 2, or Big 3. And neurological exam, to me, is the single most important thing. If they were intoxicated, they couldn't be intoxicated. CAMP is Coumadin, aspirin, Motrin, Plavix, so any type of anticoagulation. If there was a skull fracture, was it displaced, not displaced? And then 4 millimeter bleeds. And we said, well, if you meet Big 1 criteria, every single one of these, we're going to just observe you for 6 hours. We're not going to repeat your scan, and we're not going to get a neurosurgical consultation. And if we would have applied these guidelines to those 4,000 patients, what would have happened? And what we found was that actually what made sense. Big 1 was none of the patients would have failed in that criteria. Our Big 3 patients, that's an easy one too. Those are your really sick patients, anticoagulators, depressed skull fracture. We know that those patients would have met that criteria. But the Big 2 is what I call the gray zone. That's where you got to be a little bit more careful. These patients can't be sent home, but they need to be watched and observed. And you only get a repeat head scan on them is if they have a change in neurological exam. And we know that from multiple studies which looked at that, showing that, you shouldn't just have routine repeat head CTs. These repeat head CTs should be classified based on physical exam. And so we went forward with this. We said, okay, let's implement it now. Let's go forward. And it was not easy to push this through. And so the first study we did was 250 patients, prospective cohort. We said, basically, you come in, and all we looked at was Big 1. We said Big 2, Big 3, we're just going to hold off for a second. We're just going to look at Big 1, the less than 4 millimeter bleeds, not on any anticoagulation, examinable patients. And basically, we randomized them to either consultation or no consultation. And then we matched them to a cohort that we did from before. This graph here basically shows when we implemented this. The orange means violation of the protocol. And even my own partners in our own institution, after showing them the data, were like, I'm not doing this, I'm not doing this. But as you can see, it took about 7 months. And all of a sudden, all the ED residents, all the neurosurgery residents, the trauma residents, trauma attendings were all on board with this. And everyone was starting to follow Big 1. And what did we find? We found that, patients in a neuro consultation group, so if you had a neurosurgical consultation, you were more likely to be admitted, you were more likely to have a repeat head scan, and we know there was no difference in overall cost. But the one thing people always say, well, what about follow-up? Where do these patients follow up now? Overall, in both groups, whether neurosurgery followed them or not, there was a 20% follow-up. In our institution, most of these patients, if they've not had any operation, they usually follow up their PCP or neurology, or they come to the trauma clinic, and then we send them if they have further ongoing symptoms. And so, we said, well, wow, this first 250 patients, we could make a difference in ICU admission, ICU length of stay, and you start telling your C-suite people these things, they get excited. So we implemented BIG over the next few years, and again, this paper was a 2015 JAMA Surge paper, and we just looked at what happened, what was our cohort before we started BIG, and what was it after BIG, and it was a pre and post BIG. And you can see just overall for Big 1, Big 2, Big 3, we reduced the number of repeat head CTs by 35%. And that's a huge number in the number of scans patients are getting. We decreased our neurosurgical consults by 20%, and then our overall hospital costs by 33%. But the reality is that where was the biggest impact? It was in the Big 1 group, that less than 4 millimeter, not on any anticoagulation, no skull fracture, examinable patient. And if you look, 60% reduction in repeat head CTs, 81% reduction in neurosurgical consultations, and then we reduced our hospitalizations by almost a third in this cohort, and reduced our hospital costs again. And then we said, well, what if we, this protocol-based management, how did it affect all patients across the board? And if you look, here's another table looking just at neurosurgical consultation. If you look at mild, moderate, and severe, people like to get stuck on GCS and mild, moderate, and severe. So as we stratified it based on mild, moderate, and severe cases, you can see None of our, over time, really the only thing that changed was in our mild group, the 13 to 15. Our moderate and severe GCS patients still got the care that, what people termed as the care that they needed, or the neurosurgical consultation. We weren't impacting that group big 3. Everything that was changing was in that big 1. And here it is for repeat head scans, 90% to 48% in our big 1 criteria. And then if you go down to severe TBI, all those severe TBI patients who were admitted over 5 years still had a CT scan and a repeat head CT because they're non-examinable, and most of them were on anticoagulation. And if you look at hospital length of stay and ICU length of stay, again, the same thing. We all struggle with patients in the trauma bay or in the ED who need to get up to the ICU and there's no beds because you got a patient up there getting flap checks or a new trach or sitting there talking to you, but they need Q1 hour neurochecks. And some of these things are what really made the impact. And so these guidelines, we knew, decreased the consultations, the length of stay, the repeat head CTs, and the hospital costs. And then we said, what about our kids? We do all the pediatric trauma in Tucson as well. And so we said, let's look at the kids, everyone from 2 to 18. And we did the same thing, 160 patients, looking at repeat head CT and neurosurgery. And when you talk about repeat head CT and radiation exposure in children, it's a very, very sensitive subject. And it's a whole other thing. And again, the same thing, when we did this in children, the only thing we saw was that the number of repeat head CTs in the groups went down in the group that we implemented big in. And so once this came out, everybody started trying to change it. Nobody wants to use what you've done. Everybody wants their own. There was something called the Big Mac. There was something called the Big whatever, and I'm just like, whatever it is, man, just make it work. Because you can't mess up on one patient. You mess up on one patient, it changes everything, especially when you're trying to change the way we think. Surgical dogma is real, and it's stuck in our heads. So as routine, this was another group. This was done in Southern California, I'm sorry. This was out of Dr. Seiss's group, actually. 500 blunt patients, GCS greater than 15, over 15, GCS 13, and they had intracranial hemorrhage on CT. And they said, we're going to do selective neurosurgical consultation based on the big protocol, and they implemented it. But then they said, well, you can add intoxication in the big 1, and you can add anticoagulants in the big 1. And I'm just like, oh my God, there goes everything. And even when they did this, they still said that if you could still take intoxicated patients, and you could still avoid the number of neurosurgical consultations you had. And regardless of what they call antiplatelet or anticoagulation, because again, these are being managed by trauma or acute care surgeons. This was another study that said, basically not every patient needs to be transferred. They basically took the big criteria and applied it across 3 things retrospectively, and they said, well, what would happen at our institution if we applied big? And they said, you could potentially safely observe patients in DC from a local facility, meaning if you're at a level 3 and you got a big 1, you don't necessarily have to send that to a level 1 trauma center. And so I think that was one of the things that came out of this study. And then they said, well, big 3 are very critical. They need to get to neurosurgical consultation. And then big 2, again, the division to transfer, it's on a case-by-case basis. And I totally agree with that. This was done in Ohio. The state of Ohio has now implemented big across all trauma centers. Level 1, level 2, level 3 state centers have implemented big, and transfer now is based on the big criteria. But they basically said, can ACS level 3 centers keep these patients? Because remember, all the studies we did were in a level 1 institution with neurosurgical backup. At any second, I could call my neurosurgeon to come in and help us if we needed help. But these patients now were managed at level 3 centers. And here, again, the same thing. They tried to improve this. They had a level 3 center, I think 5 miles from the University of Cincinnati. They wanted to incorporate mechanism of injury. They put GCS into big, and they just and they said, well, antiplatelet too doesn't matter. And we know antiplatelet has changed. Our management of it and our fear of it has completely changed. So they replaced neurosurgical consultation with the word transfer to a higher level of care. And again, based on this updated big criteria, they found no difference in the ability to manage these patients, the patients who died or the patients who needed any intervention. And adoption of big at a level 3, they said, improves patient selection, reduces secondary over triage, and increases the safety of these decisions. And this is, in areas where you don't have 100 million trauma centers like we do here in Phoenix, it makes a difference, because I'm telling you, in Sells, Indiana, or Arizona, which only has 1 ambulance, when they have to transfer a patient out, that changes everything for the dynamics of their patients. And I think that's kind of where we talk about this paper was presented at East. Dr. Salvino up in northern Arizona presented. He said, well, we're going to adopt big to a rural trauma center without neurosurgeons, because they were transferring everything out. This has been adopted in Alaska and a couple other places. But they basically, the one thing they added, which scared me, was they said, we're going to actually reverse people. So if you come in and you're on anticoagulation, we're going to actually reverse you, and then we're going to apply the big criteria. And when they did this, they had this pre and post big analysis, and they said only big 3 patients were transferred. They kept big 2 and big 1, and what they found here was when they looked at this, they said that, none of the patients worsened clinically or radiographically. Their length of stay was 1.4 days, and they saved almost $2 million in transfer costs across institutions just by holding this into their thing. And so they basically said that you could adopt this in rural centers. And again, we're still trying to discover, make sure it's all about being safe for the patient. That's the single most important thing here. I think this was another one where they said the same thing. They wanted to implement the traumatic brain injury treatment protocol, did the same thing, non-ICU admissions, 23 observation. And again, what they found was, it's been mentioned over and over, reduced length of stay, reduced neurosurgical consultation, reduced the number of repeat head CTs. And there was no patients that had progression of injury. And so the MIST is the most important slide of the talk. More than 90% of patients are TBI are non-operative. I think trauma or acute care surgeons can, and we do manage TBI. And then, after the first 24 hours, if they're not operative, most of the times it's the acute care, critical care service that's managing them. I think patient safety must be the single most important thing that drives this. I think the big guidelines are safe, and they reduce excess resource utilization and radiation exposure to our patients. I think we can keep minimal TBIs based on these guidelines and protocols. We're just finishing the multi-institutional AAST trial. We have over 5,000 patients enrolled from 9 different centers. This will be presented hopefully next year at the AAST once we finish analyzing the data. So thank you again.